Hi, everyone. This is Dr. Sonia McGowan, and I'm so glad you're here to be with me as we talk about tethered oral tissue, oral restrictions. Um, so, we're going to give people just a couple of minutes to join us, and then we will get started. All right. Welcome, everybody who's joining us. I appreciate you being here. We've got some people joining us actively right now, so we're going to give people just a minute or so to join us and get settled and get ready to roll. I'm a little bit time compulsive, so I will not keep you waiting very long. We're going to let people get settled and then we will get started. So, Lee, hi. I'm so glad you're here. So, there is a chat box on that's available to you. So, feel free to make any comments or to ask any questions that you might have. More than happy to answer those as we go through. So, I'm so glad you're all here to learn with me about unraveling oral restrictions. So, I do have to apologize. It's kind of strange lighting. I'm in Kansas City, of all places, to give a talk at a conference tomorrow. And so my alma mater, Cleveland University, is letting me use an empty office to give this webinar today. So shout out to Cleveland. Thanks for letting me use a little bit of space. So my practice is called Covenant Chiropractic and Wellness, and we are a multi-specialty clinic in Missouri. We're actually in Jefferson City, and we really specialize in all things kids. So our big push really is to work with complex kids. And so we do a lot of functional nutrition, chiropractic, craniosacral therapy. But another big arm of our practice is what we call the SPOT for TOTS. And TOTS stands for tethered oral tissues. So you'll hear that term quite a bit. So we do comprehensive evaluation and intervention for oral restrictions. And so all the things that we're going to talk about today are the things that we do in our clinic. We do a lot of work with moms and new babies in our clinic, as well as we have hyperbaric oxygen therapy, ion cleanse foot baths, etc. And so this is my core team. So of course, I'm the owner of the clinic. I'm a DC chiropractor. We also have Renee Davis, who is our internationally board certified lactation consultant. We have Jackie Stuber, who's our physical therapist, and she is the person who does the craniosacral therapy for us. And then we have Liz Racker. She is an occupational therapist, and she does the myofunctional therapy and feeding therapy for our tongue-tied kids. And so when we talk about tethered oral tissue or oral restrictions, exactly what tissues are we talking about? So basically, there are 7 frenula in the mouth. A frenulum is a woven sheet of fascia that is pulled up into a fold with the mucosa and sometimes with muscle. And so we have 7 of these in our mouth. We have 1 lingual frenulum that's under the tongue. We have 2 labial frenula, which are at our upper and our lower lip. We also have 4 buccal frenula. So 2 cheek ties, basically, cheek frenula, and 2 lower cheek frenula. And so when we say that any of these tissues are shorter or tighter than normal, and they restrict the motion of the tongue, lips, or cheeks, then we can see impacts in many areas. So let me give you some examples. So maxillary lip tie. So your upper jaw is called your maxilla, your lower jaw is called your mandible. And so when we're looking at the upper lip frenula, we're looking at that tissue under the lip. So we flip the lip up to examine it. And so what you can see here is, for example, this child, the maxillary lip tie, lip frenula is very wide at the top, and it comes down a long way into the gum line. And so when you see this, and the picture, it's hard to see, but if you look carefully, you can see how the lip does not cover the nostrils when we flange that lip up. And so that is also another sign that that lip is restricted, when it does not cover those nostrils. Here is another one. And you can see how this tissue comes all the way down to the bottom of the gum line and wraps around. And so this is a child who, without intervention on this lip tie, will probably have a persistent diastema there, or a gap between the front teeth. Now, braces will correct that, but the minute they go a night without their retainer, after the braces are off, that gap will probably open up again. All right, so here are some tongue ties, also called a lingual frenula, lingual tie. And so this is the frenulum that's under the tongue. And so we're looking carefully at a couple of things. So for this child, you can see that the frenulum attaches very close to the tip of the tongue. You can see it's short. There's not a lot of ability to move here. We also look at where this frenulum sort of inserts onto the floor of the mouth. This is a very severe lingual tie. You can see exactly how short that is, and that it does come all the way to the end of the tongue. Not all lingual frenula come that far toward the end of the tongue, but where that inserts is important in the whole process of assessing this. And then another one you can see here, that frenulum is very short and tight. And right here is a telltale sign of a lingual tie. When a baby is crying and their tongue cups or makes a bowl like that, again, another kind of telltale sign of a tongue tie. All right, so this is a little guy from my clinic. He is the child of one of my employees. His name is Jackson. And at 2 years old, he had a very obvious tongue tie. In fact, you can see here when he tries to stick his tongue out, how his tongue bowls up. And you can actually see that he has a heart-shaped tongue. So that frenulum is all the way to the end, and it's so tight, it's pulling and changing the shape of the tongue. So the tip of the tongue looks like the top part of a heart. And so his mom was quite concerned about this, talked to her pediatrician multiple times, other professionals multiple times, and everyone just kind of patted her on her head and said, it's not a big deal. It's not really affecting him, although it was affecting him a great deal. And so this was as far out as he could protrude his tongue prior to his release. And this is right after his release. So you can see he's got a whole lot more motion of that tongue, and it just continues to get better. All right, so when we talk about the buccal ties, so these, we also call them cheek ties. So you have them top and bottom on the sides here. They're a little bit hard to get a good picture of just because of the nature of the mouth, but it is a web of tissue right here that really sort of restricts the motion of the cheeks. All right, so when we're assessing for oral restrictions, we're looking at three things. We are looking at the appearance. So we're assessing, what do the frenulum look like? Where are they? How tight? How short are they? So we're looking at appearance. We're also looking at symptoms. So we're really assessing, how do the restrictions in the mouth affect them day to day in terms of eating, breathing, sleeping, speaking. And then we also look at function. And so if we have a child who has learned very good compensation strategies, they have an obvious restriction, but they have no functional deficits, we will not recommend that the family pursue a release, because it's all about the function. And so we do a lot of work around trying to assess, how is their function impacted by the restriction that's in their mouth. So let's talk about some red flags for oral restrictions. There are lots and lots of things that, when I do a history with a family and I ask about, one thing or another, I'm listening for, because there are lots of early signs that a child may have some oral restrictions. And before we jump in, of course, this is me, but this is also my daughter. This is Libby when she was 17. At that point, we discovered that she had a very severe lip and tongue tie. Can we talk about mom guilt for a minute? Um, so of course she's 17, and so I wasn't doing the oral restriction work when she was tiny. And so despite going to the dentist as we should, and despite the orthodontist and speech therapy, no one ever examined her for a tongue tie, and it would have saved us a lot of headache. But she has since had her release, and the changes in her are really phenomenal. So, all right, so back to the red flags. So these are some of the things I listen for in a history to kind of point me as to the possibility of a restriction. So in utero positional challenges. So babies who, when they get toward the end of the pregnancy, baby flips and is breech, or baby flips and is transverse, meaning they're laying kind of horizontally across the abdomen. And we sort of specialize in working, doing adjustments that help the body balance itself to allow baby to make itself go head down. And we'll see babies who will go head down and flip right back up, or flip to breech, flip to transverse. And so any baby who had a positioning challenge tends to be a baby who we want to double check for restrictions. Lots of hiccups in utero is a red flag. And once they're born, colic, irritability, inconsolable crying, a baby who's very hard to soothe, definitely needs to be checked for oral restrictions. Babies who keep their thumbs very tight and their toes clenched. So a lot of times we'll see babies who will clench their thumbs inside their hands. Babies who clench their toes really, really tightly tend to have some imbalances and restrictions muscularly in their fascia that lead me to believe that they may have restrictions in the mouth as well. Any kind of feeding or nursing challenge should be a red flag for oral restrictions. To kind of go along with that, feeding challenges. So babies who have any sort of trouble with their suck, swallow, breathe synchrony when they're eating. We should just naturally, instinctively know how to breathe while we suck and then swallow. And a lot of babies really struggle with that. And sometimes it's because of restrictions in their mouth. Any sort of range of motion difference. So when moms bring their new babies to us, we're looking at, can they turn their head fully in all directions? Do they have full range of motion? If they do not, then that's certainly cause for concern. What we'll find is moms will say, he nurses pretty well on my left side, but not on my right side. And that is definitely cause for concern. Similar to this, any rolling or turning that's unequal bilaterally. So if baby will roll from belly to back, going to the right side, but they will not do the same thing to the left side, or they're not quite as efficient doing that, then we're certainly looking more deeply into that. Any kind of resistance to tummy time. So, people don't put their babies on their bellies like my mom and grandparents did, our generation. And so babies spend an awful lot of time on their backs. They spend an awful lot of time in containers like car seats and bouncers and bumbos and things like this. And being on the belly should be quite comfortable for an infant. And if it is uncomfortable for a baby, that is certainly a red flag, because being on your belly helps you develop the tone in your neck and back that will then lead to you being able to successfully roll, sit, walk, etc. And so if babies are resistant to laying on their tummies, that tells me that they maybe have some muscular imbalance, and that could be coming from the mouth. All right, some more red flags. Any sort of asymmetry. So any part of their body that is not symmetrical. So I'm looking at their face to see, are both eyes the same size? Are both nostrils the same size? Is one eye higher or lower? Is one nostril higher or lower? We also look at the shape of the head. So if there's any sort of asymmetry there, if we have any sort of flat spot on the head, and as well, we're looking at torticollis. So torticollis is when you have some rotation with lateral flexion. So a baby's head is sort of stuck like this. That is a severe, significant red flag for oral restrictions. So this is a baby here who we've worked with for a long time, and you can see she definitely has some head shape differences, and we were able to correct that. Any sort of difference in facial development, particularly in babies who have torticollis. So when their heads are stuck sort of in this position, it will change the shape of their face. And so one eye will be higher, generally one nostril will be higher, it will change the symmetry of the mouth, and generally one cheek will also be larger than the other side. And so any kind of differences in that sort of facial development, we pay a lot of attention to. Head control issues. So if there's too much head control, we worry. If there's too little head control, we worry. And so a lot of times parents will bring their newborn to me and say, oh my gosh, he's so strong, he's already trying to hold his head up. And before I knew what I know now, I remember when my son Rowan was born, and I wrote in his baby book, oh my gosh, he just rolled over at 3 days old. That's not okay. It's not normal, but I didn't know that then, right? I thought, wow, he's so advanced. It's so amazing that he just rolled over at 3 days. And so that is too much head control. Like when he was in the nursery, right after he was born, the nurses were like, what's going on with this kid? Because he was fighting the blanket. He was unraveling himself from his blanket and trying to, do all kinds of stuff as a brand new baby. I just didn't know that was too much tone, and that wasn't good. We also look for milestone challenges. So milestones that are too fast, too soon, or too late, we definitely pay attention to those, as well as tone imbalances. So if a kid, seems stronger on one side than another, maybe their SCM muscle here, one is tight, one is not, or we see, kids who have an odd crawling pattern. So maybe they kind of drag one leg behind them and do a funny little army crawl. Anything like that is definitely something not to ignore. All right, so some more red flags. So any sort of tension, any kind of compensation. So that odd crawling, for example, that I was telling you about. And postural issues as well. So one of the things we do with new babies and even toddlers and older kids is, we take pictures of them and their posture so that we can assess, do they have a high right shoulder? Do they have feet that toe in, for example, or a head that tilts to one side? And even in infants who aren't yet weight bearing, when we lay them on the table, how do they lay? A lot of times babies will sort of be C-shaped, right? So instead of nice and straight, they're curved off to one side. And those are things we definitely pay attention to. We look at tongue movement. So are they able to move their tongue in all directions that they need to? If their tongue posture is low, we pay attention to that as well, because a tongue should rest on the roof of the mouth. The tongue is what drives all development in the body, and it is what determines the shape of the roof of the mouth. And so if the tongue cannot rest easily at the roof of the mouth, we're going to have differences in the way that palate or that the roof of the mouth is shaped. And so kids who have a low tongue posture, kids who tend to have a little bit of a tongue thrust, so their posture is just pretty significantly tongue out like this, we definitely want to intervene there. And then any sort of oral habit. So babies who suck their thumbs, who suck their fingers, who are very insistent on a pacifier, especially the whole pacifier thing as kids get bigger. We really should not have kids using pacifiers past about 6 months. It creates a lot of issues, but kids will often seek that because having something in their mouth protects their airway. And so when we've got, a kid who's 2 or 3 or older who has an oral habit like a pacifier, we definitely want to dig a little deeper there and see what the motivation might be. We also look for a distended abdomen. So if a a child's belly is very distended or bloated, it's often because they are swallowing a lot of air. And that happens because the tongue, the lips or the cheeks are restricted and they end up swallowing air inappropriately. Any sort of open mouth posture is certainly an issue. A lot of times, an open mouth posture is paired with a tongue thrust, like I mentioned. Believe it or not, for older kids, having astigmatism has been correlated with having a tongue tie. Any sort of speech errors that are beyond what's expected for age, any sort of lisp, any kind of omission or substitution of sounds definitely needs to be evaluated. And then feeding challenges as well. So we see kids who are really selective about what they will eat. They choose foods that are easy to eat. They avoid foods that take more skill and coordination and strength to eat. So, for example, kids will love things like macaroni and cheese and mashed potatoes and things like that. They won't want things that tend to be crumbly, um, things that tend to go into a lot of pieces, like crackers, because it takes a lot of skill and coordination to sort of gather all that up in your mouth into a ball to be able to swallow that. Kids will avoid things like meat. They don't want to eat steak or cheeseburgers or things like that because it takes a lot of strength to chew that up. And then, of course, a lot of coordination to be able to swallow it. Kids who gag very easily, who choke often, are definitely issues. We see kids who tend to be messy eaters, right? Because they can't, coordinate their lips and their tongue to keep their face clean and to control their food appropriately. We see kids who dip a lot. So they'll, every little thing they're using ketchup or ranch or whatever. And that sort of acts like a lubricant and makes the food a little bit easier to control and coordinate and swallow. And then on a similar line, these are often kids who will drink a lot as they're eating their meal because they need that fluid, that liquid, to help them get their food down. All right, so more red flags are attention problems. So kids who may look like they have symptoms consistent with ADD or ADHD, I always want to check them for oral restrictions. That diagnosis is often the result of sleep disordered breathing. And sleep disordered breathing is generally caused by oral restrictions. Also, the other thing about that is, too, that behavior medications will often disrupt sleep as well. And so we definitely want to pay attention when a child has any sort of attention challenge that we look in the mouth for sure. Sleep issues, snoring, kids who breathe with their mouth open, breathe through their mouth instead of through their nose, that's definitely a problem. We look any kind of sleep issue like trouble going to sleep, anxiety at nighttime. We look for kids who are restless, who are just all over the bed. They're like a tornado. Their sheets are a mess in the morning. And of course, snoring, or even if it doesn't rise to the level of snoring, if it's audible breathing, we definitely want to look a little deeper there. And then anxiety is a really common manifestation of oral restrictions. So this is a patient of mine. She came to us a couple of years ago with anxiety and digestive complaints. And when I examined her, we discovered she had a very significant tongue tie as a teenager, similar to my daughter. And so we did all the things, sent her for the release, did the post-release therapy, and you can see in just less than 2 months the difference in her. Like, her face looks just so much different. And digestive problems went away. Anxiety got better as well. All right. So most people look at me crazy when I tell them that oral restrictions affect movement of the whole body. So it's not just a mouth issue, it's a whole body issue. And so restrictions in the mouth are reflected in other parts of the body. So the mouth mirrors the pelvic floor. And so a balanced pelvis promotes balance in the mouth. So that's one of the reasons why we advocate so heavily that kids and adults with oral restrictions be adjusted regularly. we have something called anterior head carriage. So this is when people, their chin juts out, so their head is very far forward. And what we see there is that so the tongue connects to the chest and the diaphragm. And when a person swallows, it promotes flexion. And so it shortens the space in the front here. And so that will promote anterior head carriage because a person is trying to compensate to be able to swallow more effectively. And so areas of compensation can return with growth spurts and the development of new skills. So sometimes we'll evaluate an infant and we're not particularly concerned about oral restrictions, but I will always keep my eye on it because as a baby gets bigger, their body grows, but the frenulum doesn't necessarily. And so we can see an emergence of new functional deficits as a baby gets older. And so this is why the multi-specialty approach that we use in our clinic gives such significant results. And so people ask me all the time, what if I do nothing? If I have a baby with a tongue tie or a lip tie, what if I just leave it alone? What are the consequences of that? And there are a lot, honestly. And so we see generally in unaddressed oral restrictions, we will often see feeding challenges. So from infancy through childhood, we'll see things like selective eating. We'll see a lot of digestive issues. So lots of belly aches, lots of bloating, lots of gas. And also it's very common to see food allergies and sensitivities. And because of all of these digestive and food issues, selective eating issues, sometimes we see kids who don't grow quite as robustly and develop quite as well as they should. Sleep issues are big. I can't tell you how many kids come to my practice, and the number one complaint from mom and dad is my kid just does not sleep. And so we'll see kids who are very restless, who wake frequently in the night. They breathe through their mouth. They have sleep disordered breathing. They have nightmares. They just don't have good quality sleep. And that really creates lots of effects through the rest of their daily lives. Very common to see behavior challenges. So poor focus, difficulty sitting still. We see things like anxiety. We see speech difficulties. So kids who have delayed speech or, articulation errors, stutters, things like that. And then dental challenges. So we have dental decay. It's really common for kids with an upper lip tie to get milk and foods and other liquids hung up in between the lip and the teeth, and that promotes decay of those front teeth. We see lots of cavities, and generally these are kids who are going to need orthodontia. So they may need braces, they may need palate expansion. And so I'm pretty consistently telling folks, you got to choose your hard. I know you're nervous about sending your baby or toddler to a dentist to have a laser release of these tissues, but doing this now is going to save you so much hard later in terms of, sleep, behavior problems, issues at school, postural problems, but also things like orthodontia. I mean, had I known with my daughter Libby, with her severe tongue tie and lip tie, if we had done this sooner, maybe we could have avoided, thousands of dollars in braces, right? And so when you're looking at how to address an oral restriction, it's really important that you, as a parent, have a team around you of people who really know what they're doing when it comes to oral restrictions. So in my clinic, our TOTS team is pediatric chiropractic, lactation consultation, craniosacral therapy, myofunctional therapy / feeding, and then the release provider. And so what we're trying to do with all these is to really promote nervous system regulation. We're trying to work with that child to desensitize the mouth, because generally these are kids who don't do well with having us examine them in their mouth. And so we've got to desensitize them, get them used to having that it's safe to have things around the mouth. And also it's amazing how most of these kids have a very poor awareness of their cheeks, their lips, and their tongue. And so the therapy that we do ahead of time really concentrates on increasing their awareness, the coordination, the strength, and the stamina of the lips, the cheeks, and the tongue. And so we always insist on what we call prehab. So to us, it's non-negotiable because before we will refer a child for a release to the dentist, we do therapy ahead of time and we do therapy after. And the reason we do this is because it increases the good outcomes. It is a fast procedure, but when it's a child, you worry about it. It is a procedure. It does create a wound. And so you want to have the very best outcome possible. You want to not have to go back and have a revision of that release. And so doing therapy ahead of time increases our good outcomes. It helps us establish a baseline of where that child is in terms of function and in terms of tolerance. And it allows us to develop a comprehensive plan for their care. And there is such a thing as optimal timing of release. So we would never, rarely, send a child directly from assessment to release. Now, if it is a very small baby and their issues are severe and they're not gaining weight, they're not nursing appropriately, they're not eating, we will use our clinical judgment and sometimes send straight for a release, but then we do the therapy afterward to make sure all goes well. So the optimal timing of release is very important, and we use that prehab therapy as a way to determine what time is the right time to send for the appointment to the dentist for that release. Again, it allows for the practice of oral touch for both mom and child. Because it's a sensitive area, because this is intense work, they need some practice to get used to that. And then it allows us time to educate the family and allows us to manage the expectations of, what's going to happen? What's baby going to feel like afterward? How much pain will there be? What sort of exercises need to be done? How much therapy needs to be done afterward? So it really helps us manage those expectations. It also, when we do chiropractic and craniosacral together, it really reduces tension and stress in the body. It improves strength, coordination, and function. It teaches new muscle patterns, motor patterns, because we need for a baby to be able to move their tongue, in babies and kids, in all ranges of motion. If they're older, we're teaching them how to do what we call lingual palatal suction. So suctioning the tongue to the roof of the mouth is a very important skill before they go to release. And it helps us sort of create this systemic response to treatment. So, for example, when we took my daughter Libby for her release, it was amazing the changes that we saw in her almost immediately. So her anterior head carriage got better, her posture improved almost immediately. And so it really was this systemic change in her. She slept better, headaches went away, it sort of changed the orientation of her feet. Like it was really amazing, and it was a systemic response. It also improves the chances of a successful release because we want baby to be prepared. We want to set the baby or the child up for success. We want the dentist's job to be as easy as possible because it's a skill that they have with a very powerful tool, and we want to be as safe and effective as possible. It preps for and helps us guide wound management. So, there are stretches and ranges of motion exercises that parents need to do with kids after the release, and that needs to continue in the home. And so we spend a lot of time with families to really prepare them for that, teach them how to do that. And then we support parents through the process because they're worried, they're nervous about this. And we just kind of guide them along, hold their hand a little bit as we make it through that. And so when we look at how the pieces fit together, we're looking at it like a roadmap. We have lots of pieces here. So pediatric chiropractic, lactation consultation if that's necessary, sometimes feeding therapy, myofunctional therapy, and craniosacral therapy. All of these get the child ready for release. Once the release happens, then we go through and do it again post-release, just to help teach new ranges of motion, increase strength and stamina, coordination, and then, help them unlearn some of the compensatory patterns that they have developed because they had such restricted motion in their mouth. And so one of the things that I say all the time at my clinic is that our practice is brain, not pain. And so we do a lot of, deeply neurological work with people. That's what we love to do, and it's what we're good at. We're not the, ouch, my neck hurts kind of chiropractors. In my practice, we definitely are brain-based all the way, and that's why I think we see such phenomenal outcomes with the kids, the complex kids, and the kids with oral restrictions that we see. And so what we know is through chiropractic, craniosacral therapy, feeding therapy, etc., when we change the structure, we change the function. And so as we, work to adjust the body, to regulate the nervous system, changing that structure improves the function. And so that helps us just really change the trajectory of that child's life. And so we know that the why matters. We talk about this a lot, that, there are no purposeless behaviors and there are no bad kids. And we have to dig into finding out the why behind the things that we see in kids. And sometimes the why are oral restrictions. And so it's something we cannot ignore. We need to be assessing these kids and intervening when it's necessary, because correcting restrictions in the mouth can have just huge implications for kids and even adults. We've had adults come to us for a while. Our oldest patient was 61 years old, who had prehab and had a release. We recently broke that record. Our oldest patient now is 62 years old. He has lived with one of the most severe tongue ties I've ever seen his whole life. And somehow they heard about us. They live far away, but they heard about the work that we do. And wife drug him to us because he has such severe snoring that she was not getting any sleep. And she's like, it's been 30 years, something has got to give, And so sure enough, we found a very, very significant tongue tie, did the therapies, sent him for a release, and it's just amazing the changes that we're seeing. So we have no age limit at our clinic in terms of who we will assess and work with when it comes to tethered oral tissues, because even at 62, he's getting a much better quality of life than he had before. And so here is my contact information. It's easy to find me. You can look on our website for more information, covenantwellness.net. If you are interested, if you have a child or you're a professional and you want to have more information about the things that we do, definitely reach out. You'll see my email address there, our physical address as well. So so that's just a little bit of information about oral restrictions in kids and adults. Does anybody have any questions? We'll hang on just for a few minutes in case anybody wants to ask any questions about the material that we talked about today. Some of the things people often ask me, do tongue ties run in families? They do. Really, really common to see if one sibling has oral restrictions. It's pretty common that the other ones will too. So we generally look at everybody in the family if they have some functional concerns. All right, any questions? All right, so hi Sierra. She says, for a newborn, what is the ideal timing usually to have it corrected? Generally, sooner the better. We really base it case by case. So we will evaluate carefully. We'll look at any sort of functional limitations that they may have. I'm mostly concerned about how the feeding is going. And so we do not want babies losing weight. We want them to be able to feed vigorously and appropriately. We want a good therapeutic suck. We want a nice mouth shape. We want good control of suck, swallow, breathe synchrony. So just sort of depending on what their symptoms are, what their functional limitations are, um, that guides us to optimal timing of release. But generally, with babies, we don't like to piddle around too long. We want to get that taken care of pretty quickly so that uh, baby isn't setting up long-term compensatory patterns. Usually my babies are able to get milk because I have a very strong letdown. Yeah. So that is often what saves tongue-tied babies and lip-tied babies is that, they're basically, drinking from a fire hose. And because of that, they don't have to have a lot of strength or coordination. They don't have to have, a super coordinated suck because they don't have to work very hard, right? Because your letdown is so strong. Um, so they're making it in terms of nursing, but like I talked about, there are going to be lots of other potential implications as they get older around speech and dentition and breathing and sleeping and things like that that you would want to keep an eye on for sure. Exactly, which is why my doctors never think it's an issue, right? But it hurts horribly, and it should not. Nursing should not hurt, and so I would definitely recommend having your baby evaluated. Not by just anybody, though. It doesn't have to be me, but just to make sure that whoever evaluates your baby truly has education and experience, and that they understand that appearance is only part of it, that we have to look at appearance, symptoms, and function when we are making a determination about tongue and lip ties. So Erin says, wow, thank you so much for all the information. I brought my 7-month-old for her 6-month checkup with Dr. Strong last month. Yay! And she discovered oral ties that our previous pediatrician didn't check for. I'm so thankful for her. I'm keeping an eye on things. Fantastic. You're in great hands with Dr. Strong. So for people who don't know, back in January, my practice brought on a pediatrician. And so she is a DO and she does well visits. She does same day sick visits, regular scheduled sick visits as well. And so she is definitely on the fast track of learning about tongue, lip, and cheek ties. And so she's developing a lot of skill in terms of being able to examine and assess for that. So you're in excellent hands with Dr. Strong. I'm really glad that you came to us. All right. Anything else? Other questions that you might have before I let everybody get on with their day? All right. Okay. Last call for questions. All right. Well, guys, thank you so much. If you have any questions at all or you need additional information or you want to make an appointment, of course, you can call the office. If you have questions that are specific to this, feel free to email me. I'm happy to answer any questions that you have, or if you need additional information, we're awfully glad to help you with that. So again, thanks so much. Appreciate it. Don't miss our next monthly webinar in July. So they're always the first Friday. So July 7th at 2 p.m., I will be talking about kids and chiropractic care. People say to me all the time, why on earth would I bring a baby or a toddler or a child to a chiropractor? Well, I tell you what, they're the first people you need to be taking your kid to, and I'll be talking to you about why I know that to be true. So Lee, thanks for coming. Thanks, Erin, Sierra, everybody for coming. It's been a real pleasure, and we'll see you hopefully at our webinar on July 7th at 2 p.m. Central.